Ahoy, me hearties! Dr. Peterson here to bring you some swashbuckling education. 'Tis a beautiful day to be on a boat. I'm here with me mates from Stillwater Fire on the St. Croix River, and we be looking for some vessels to plunder. Well, not really, actually. Well, the Stillwater Fire and the St. Croix River part is true, but we have no intentions of plundering anyone today. In fact, I'm kind of like the anti-pirate, because I'm going to be giving you some nuggets of wisdom. So here we are on the backside of the COVID-19 pandemic. We're trying to figure out how we get back to normal, or whatever that means to each of you. Our team at Regions EMS strongly believes that hands-on, in-person education is absolutely the best way to learn. I'm proud of the work we've done by pivoting to more of a digital platform, and fortunately our video production team was more than ready to keep you informed throughout the pandemic. So where do we go from here? Well, bad jokes, embarrassing outtakes, and hopefully another spooky Halloween extravaganza later this year. For right now though, let's hit on some hot topics, such as airway management, an update from the Regions Hospital Trauma Program, and the very latest from the news desk. So buckle up and get ready for the Regions EMS Update Summer Edition. Avast ye! As part of our ongoing continuous quality improvement, I'd like to take you all through a review of our current airway management recommendations and expectations. As medical directors, we get an automatic notification anytime certain types of patient care reports are posted. For today's purposes, this includes any advanced airway interventions. We review all of these notifications and discuss any interesting or concerning cases twice a month during our medical directors meetings. We've recently noticed a few trends that I'd like to address so that all of you understand our philosophy and where we are coming from. And to be clear, everything I will mention is consistent with how I manage airways in the hospital. So stand by. Here are Dr. Peterson's 5 tips to make you a better airway master. Okay, so we've been emphasizing the use of the bougie for years now. Many of you get it, but we still see airway videos without the bougie. Maybe you were trained on the stylet and that's what you've always done, but let me challenge you for a minute. The research that has been done on bougie versus stylet is pretty clear that we should be using the bougie as our first go-to airway device. Your chances of successfully passing the tube on the first attempt are statistically higher with a bougie than with a stylet. In fact, Hennepin County recently published a paper in JAMA, one of the most highly respected medical journals, that showed that even in an ER setting with experienced physicians, over 750 patients, their first pass success with stylets was 82%, and with a bougie it was 96%. Let's put our egos and traditions aside here and really think about what is best for the patient. I would argue that if you're uncomfortable with the bougie, all the more reason to practice and use it as much as you can. All of the medical directors use the bougie routinely in the ED because we have studied the data and truly believe this is the best care for our patients. If you disagree, by all means do your own research, send your thoughts to regionsems@healthpartners.com and change my mind. Next, let's talk about the video laryngoscope. Most of you don't have any issues with this, but there are a few of you who still prefer a standard non-video laryngoscope. Again, I would take you back to the research data. In a pre-hospital environment, using a video laryngoscope improves your first attempt success rates by a statistically significant margin. So what, you say? Well, did you know that a successful first attempt intubation in a cardiac arrest patient improves their chance of ROSC by over 50%, and their chance of surviving to hospital discharge with good brain function by over 25%? So again, we have to go back to the key question, what is best for the patient? Videolaryngoscopy also allows the airway management to be recorded, which allows us to review the videos for quality assurance purposes and to guide our education. This has been incredibly helpful for us to identify practices and trends that either work well or need to be corrected. It also has helped us on several occasions to show the hospital that you got the tube when it became dislodged later in the ED. I'm going to give you 2 quick tips that we see on a regular basis that will improve your videolaryngoscopy skills. The most common mistake we see is that the blade is inserted too deep. You might have a great view of the vocal cords, but the camera is so close that you don't have any room to manipulate the bougie into the larynx. If you get the blade in the vallecula and use good technique, you'll have plenty of room to maneuver the bougie. Remember, if you set yourself up for success, you're more likely to succeed. The second tip I want to give you is regarding hyperangulated blades. What's that, you ask? Well, basically any blade that's not a standard Mac or Miller shape. Those of you with CMAC devices have the standard Mac 3 or Mac 4 blade, but some of you also have the D blade, which is a little bit more hyperangulated. Those of you which use the UE scope, this comes with a built-in hyperangulated blade. And if you compare it to a regular Macintosh blade, you can see that the tip is angled to a little bit more extreme degree. That also means that the camera at the end of the blade is pointed more towards the patient's anterior rather than in your direct line of sight. Why that's important is when you start to advance the bougie, you may not see the bougie in the screen like you expect to when it's in your normal direct line of sight because the camera is pointed much more of an anterior angle. If you have a CMAC device, use your regular Mac blades first and save the D blade for the really anterior airways. The D blade can sometimes make it harder when the airway is more anatomically normal. Second, the D blade comes with its own special stylet. This is the one situation where you should be using the stylet with the tube instead of a bougie. Again, only for the CMAC users. Third, if you have a UE scope, you must use good technique. Lift up and away to keep the camera less anterior instead of tipping back, and you might also want some cricoid pressure as well. All of this takes practice, and we are always willing to set up some airway time with our mannequins, so just reach out to your EMS leader. There has probably been some confusion as we haven't really emphasized this, but our current patient care guidelines allow for 2 intubation attempts total. We've seen several 3-attempt charts recently, and here's the deal. If you truly believe that an endotracheal tube is better for your patient's condition than a supraglottic airway, by all means, do the right thing for the patient and explain why you did it in your documentation. The reason we have limited to 2 attempts is because our airway video reviews have shown that it is way too easy to get tunnel vision when you're managing an airway. Every time you jam something around in the back of the patient's throat, you are causing more bruising, swelling, and bleeding. And if it is taking more than 2 attempts, you really should be doing something else to maintain ventilation and oxygenation and get them to a hospital where there are other tools and resources that might be more useful. I would much rather have you deliver a patient who is being well oxygenated and ventilated with a BVM face mask than a patient with an endotracheal tube who is hypoxic for a period of time and now has to stay intubated for a week until the airway swelling goes away. Ultimately, it comes down to what is the right thing for the patient in front of you. If that means it's an endotracheal tube, then go for it, but know when to cut bait if it's not going well. Kids are not just little adults. In fact, I heard an anesthesiologist once say that kids are actually more like little fat adults from an airway standpoint. Combine that with the fact that when we have gone back over the last 6 years' worth of airway data, for the number of paramedics in our system, each of you will only intubate a kid once in your career. For something that rare and that high risk, I can't justify it, especially since there will almost always be another safer way to oxygenate and ventilate. Sure, there are theoretical situations like airway burns and anaphylaxis, but the reality is that those cases are such a tiny percentage of pediatric airway cases that I doubt that anyone watching this video has ever had a case like that where it was truly impossible to ventilate by anything other than an endotracheal tube. If for some reason you do have a situation that requires an endotracheal tube, make sure it is an honest clinical decision and not just because you think you're a good medic. And that better be the best written chart in the history of EMS. The research evidence is just not there to back you up, so we have to always bring it back to what is the right thing to do for the patient in front of me. Look, we read a lot of charts. Some of you do an excellent job of painting a picture with words and describing your clinical decisions. Some of you simply document a timeline of events. There are several things to keep in mind here. The hospitals actually do look at your documentation. This is helpful for a number of reasons, and sometimes you have the only hard evidence of a critical arrhythmia that will change a long-term management decision. Second, it helps us understand what you are thinking as medical directors so that we can either be reassured that we are teaching appropriately or redirect our education efforts to clarify a topic. And third, your chart is part of the patient's legal medical record. This will be the basis for any future complaints or court proceedings. For a good example of how this could help or hurt you, go back and look at the paramedic testimony from the Derek Chauvin trial. Remember that the standard of care expected of you is based on our patient care guidelines. For example, if you make 3 intubation attempts and for whatever reason the patient has a bad outcome, your documentation better justify why you deviated from the guidelines, because we can't back you up if it doesn't. There are some excellent paramedic documentation resources and templates out there, so work with your agency leadership if you have any ideas. And with all of this information, my goal is not to scare you. It's to help you understand the importance of what you are doing and ultimately make you better medics. If any of this pressed a button with you, I'd like to hear from you. Hit me up at regionsems@healthpartners.com. Today we have some exciting news to share. I'm here with Dr. Pate Ieha from Regions Hospital about a transfer of ownership in the trauma program at Regions Hospital. So Dr. Ieha, why don't you introduce yourself, tell us who you are and why we should care.
So yeah, I guess transfer of ownership is a little bit strong, but I'm Pate Ieha. I joined the trauma group back in 2015 and have been working closely with Michael McGonigal, who's been the trauma medical director at Regions Hospital for almost 30 years. And over the last couple of years, I've had the good fortune of working as his assistant trauma medical director, learning the ins and outs of the performance improvement program and the program as a whole at Regions. And as of January 1st, he has now relinquished that role to me, and I am the trauma medical director. And yeah, it's going to be my face on a lot of and my signature coming on a lot of the emails coming from the trauma program. And I just want to maintain a good working relationship with our EMS colleagues.
Awesome. So this was a planned takeover. This wasn't a sudden change, unexpected or anything like that. This has been in the works for a while.
Yeah, definitely not unexpected. It was something that Dr. McGonigal gave a lot of thought to ahead of time, and so really has been 5 years in the making.
Sure.
And
yeah, and Dr. McGonigal, he built the Regions trauma program, so there's some pretty big shoulders that you're able to stand on now to continue the work that he started at Regions Hospital. To be one of the foremost, trauma centers in the Twin Cities, and definitely the only one in the East Metro. So interfaces a lot with what you guys are doing out in the field for sure. I have to ask, so Ieha, is that the common spelling, O-N, or is it E-N? I get that all the time with my name, so
really?
with Peterson. So
yeah, it's exactly like it sounds.
Yeah, okay, I'm sure it is. So tell us about where you did your training, any projects that you've been involved with, any areas of interest specific in trauma that you have.
So I did my general surgery training at the University of Minnesota. As some people know, but not everybody knows, the Regions Hospital is a major site for training of general surgery residents. We get almost all of our trauma experience at Regions Hospital. So I've known Dr. McGonigal since 2005 probably, when I first start taking some trauma call as a medical student. And I graduated from there in 2014 and did my surgical critical care fellowship at University of Minnesota and spent a lot of time at Regions there too. And so pretty inbred if you're thinking about training within the Minnesota. But
like we were talking about earlier, you've been drinking the Regions Kool-Aid for quite some time.
Absolutely.
Yeah. As have I, so there's nothing wrong with that.
Hey, if you like the flavor. I think that point though, I think we've done a pretty good job of bringing other outside influences. Some of our trauma partners have trained at other institutions, notably Cook County and Shock Trauma, some of our more recent hires. And certainly getting ideas from other places is important. And so even though I'm inbred, we certainly don't want to keep the entire program inbred.
Sure. Sure.
And I think that listening to those voices and really putting a different lens and scrutiny on some of the things that we do normally has been very helpful.
Sure. And so as EMS providers, you've been involved with several fairly large research projects and clinical studies that we've coordinated through Regions EMS. TXA in trauma and head injuries. We've been working with some seizure medications in the past. So let's just talk a little bit about what are the current initiatives going on at Regions Hospital right now. Are there any projects in the works, research? I know with COVID, everything's kind of just been jumbled up and taken a pause, but what do you see in the coming year or two from a progressive, pushing the envelope, studying a new intervention or treatment option?
Yeah, I don't know if there's anything coming forward as far as a new intervention. I think some of the focuses that we have right now, first of all, is this year is our trauma verification, so there'll be a lot of communication from us as we try to really hone in on some of the things that we do, try to make sure that we do them better if we can, and looking for areas of improvement. And so, but along those lines, we know that it can get very tedious to hear from us only when we think that there's something that we could do better, and so we're trying to make it an emphasis to also give some kudos and good catches, especially when we pick on something remarkable that you guys do every day but sometimes don't hear it, and so that's something that we're trying to put some emphasis on. As you guys are all aware, I think we've seen a significant uptick in penetrating trauma across the Twin Cities, but we certainly have felt our own burden of that. And Regions just got confirmed to be one of the sites in a nationwide firearm study put on by the American College of Surgeons Committee on Trauma, the National Committee on Trauma. So we're excited about joining that and adding our data to the broader collective and learning more about penetrating trauma and how we can impact that.
Sure, excellent. So let's leave people with just a nugget of wisdom here. So something simple. Let's talk about the GCS score that we calculate all the time on trauma patients. We know that it's a scale that we use to assess somebody's mental status, but what does it mean? What do you do with that information? Because it is one of those critical pieces of information anytime a crew is bringing in a trauma patient that they get asked by either the MRCC operator or the ED. So little maybe background or whatever little nugget you can give us here on why do we calculate a GCS and what is it good for?
Well, for practical reasons, GCS is one of our TTA criteria. So a depressed GCS is important to know before the patient arrives to allow us to bring to bear the full trauma team if it's appropriate for that patient. As you've already mentioned, it's a fairly reliable inter-provider assessment of the mental status. And because it's fairly simple, it can be reproduced and used to track real-time changes in mental status. What do we do with that information? Well, I know for one that us as trauma providers and our neurosurgeons and neurointensivists really value that assessment as early as possible as giving us some insight into potential prognosis. There's some data out there that particularly links the motor component of the GCS to prognosis, to outcome. Mm-hmm. And so, but then a lot of things change. So patient may become hypotensive, patient may get sedating medications and things en route in order to maintain the safety of the transport. And so then it clouds the picture. So we're not necessarily seeing the true GCS, if you will, when the patient arrives in our trauma base. So knowing what things were in the field is very helpful to us.
Sure. And there's other things, obviously, that affect the GCS that can complicate it. Most commonly, we see a lot of intoxicated patients where that you would think that would lower their GCS. But you mentioned the motor score. Is there something with the motor score specifically that's less affected, do you think, by some of these other intoxicants that maybe makes that a little bit more reliable? Because eyes are closed, maybe the speech is garbled or confused, but we can attribute that to any number of things.
Absolutely, you're right. The verbal score and the eye score are impacted by a ton of things. Mm-hmm. We typically think that a significant change in the motor score usually has to do with traumatic brain injury.
Okay.
Not always true. I mean, severe intoxication and other substances can impact it, but certainly we get to sort that out when the patient gets there. So that information is important to.
And for
regardless.
any specialty considerations, trauma trumps everything else. So if there's any question of trauma and you have a low GCS, regardless of what else you think might be going on, the trauma team activation should be the first thing that you consider if there's any question of whether or not there's trauma involved.
Right. First rule of trauma, it's the trauma until we've gotten them evaluated and proven that it's not.
Sure.
So that's where our emphasis would be.
Excellent. Well, thank you, Dr. Yeha. We'll get into some of the more finite aspects of the GCS at some point in the future. Just wanted a little high-level overview, some wisdom to show you guys how smart he is. The resource that we have here at Regions Hospital in trauma and have had for quite some time now. As always, any questions, feel free to forward them to regionsems@healthpartners.com. We'd be more than happy to pass them on to Dr. Yeha or someone on his team to get you some answers or some further education. July 1st is traditionally the start of a new educational year for medical education. So I'd like to introduce our new EMS fellow, Dr. Joseph Lippert. Here we go. All right, so we're entering a new era here at Regions EMS. We said goodbye to Dr. Finn about a month ago. He's moving on to bigger and better things, fortunately here in the Twin Cities, so maybe this isn't the last that we'll see of him. And we welcome Dr. Joseph Lippert, who hails to us from Omaha. Home of the College World Series and TD Ameritrade Park, formerly known as Rosenblatt Stadium, the Henry Dorley Zoo, and the iconic Ranch Bowl music venue. Did I miss anything, Joe?
I'm a big Creighton basketball fan, so that's also a big thing that's there. And Nebraska football, too.
Perfect. But you know what? This is kind of stupid. We're both vaccinated. We don't need to do this over Zoom. Let's just do this together in real life.
I agree.
So this is much better.
I agree.
We can do this in person here. So Joe, you're from Omaha. We mentioned a little bit about some of the activities that there are in Omaha, just some of the big things that I remember from my days growing up in Nebraska, if you knew that. And so tell us a little bit about your education, your training, and some of the experience you had before medical school that led you into EMS.
Sure. I went to Creighton and I got my bachelor's in emergency medical services. So I started off as an EMT and got my paramedic license and everything throughout my undergrad and worked for as a paramedic for about 2 years for a private transport company and decided I wanted to go on to medical school. And so I went to med school at Creighton, fell in love with emergency medicine, and that's where I stuck. And so I went to University of Nebraska and completed my residency. And now I'm glad to be here at Regions pursuing my EMS fellowship, coming full circle back around.
Cool. So would you call yourself a recovering paramedic or a paramedic, step up or whatever?
A little bit of both.
Okay, so there's hope for all of you paramedics out there. So tell us a little bit then about what kind of drew you to EMS. Was that always your passion growing up, or what kind of was the sentinel event for you?
Sure. I remember arriving on scene at a high school basketball game, and one of my friends was down, got knocked out while playing basketball, and I remember, I can't do anything about this. I don't know anything. That drew me. Fostered an interest wanting to pursue medicine, and so that's where I kind of went from there. I just wanted to learn how to respond in these emergency situations, and so I started off with EMT, and it just went off from there.
Cool. So you're going to be spending a lot of time with our services here in the East Metro. Right now you're doing a bunch of ride-alongs just to get your face out there, to get to know some of our crews so they can get to know you. With your previous background, I'm sure it'll be a pretty seamless transition right into where things are going. And you have some big shoes to fill too. We had some pretty good fellows in the last couple of years, so I have no doubts that you will rise to the challenge and be an excellent resource and not only represent Regions, but also help our agencies that we work with, all of you, to provide top-notch, excellent care as a progressive EMS system that is well-respected and known throughout the country. So. Thanks, Joe, for being here. We're excited to work with you over the next year.
I'm glad to be here.
All right. Joe's going to be great. He brings a wealth of experience. We've had several other fellows from Nebraska that have been very successful here, so hopefully you get a chance to meet him and interact with him, and please try to be nice. In other news, ECMO is back in business at Regions. Those of you who have had ECMO team activations in the last 6 months most likely have been going to the University of Minnesota. Well, as of right now, ECMO is back in business at Regions. So when you call the ECMO team to activate, They will likely be directing you to Regions Hospital unless you are on the west end of St. Paul, in which case it might still be closer to go to the University of Minnesota. Call the LifeLink dispatch to activate the ECMO team. You can see the number on the screen, as well as the inclusion criteria for eligible patients. In the East Metro here, everyone has done a great job of keeping that at the forefront, but the key thing is as soon as that first rhythm is shockable, whether it's through your monitor or a first responder's AED, you need to be thinking ECMO and get moving as soon as you can. COVID. We got to mention COVID. So you're hearing in the news about this Delta variant. Fortunately, we have not seen a significant spike here in Minnesota yet. Obviously, that could change in the coming weeks, as the latest statistic I heard is about 86% of the cases in the US right now are the Delta variant. For people who are fully vaccinated, the symptoms are mild, if any at all, and almost all of the hospitalizations and deaths nationwide are amongst people who are not fully vaccinated. So just another plug for the COVID vaccine, as well as just still being vigilant for those high-risk patients, wearing a mask, wearing an N95 if it's a really high-risk situation, and especially if there's any possibility of aerosol-generating procedures. So even though we're kind of through it, we're not really through it yet, so we need to keep our guard up. But everyone in the Twin Cities in Minnesota is doing a pretty good job because we are just not seeing the spikes that some of the other states are seeing. So keep it up. It's summer. We're coming to the end of summer. It's been a hot, dry summer. There's no end in sight at this point. Just remember, you guys are working outside. You're doing a lot of manual labor, lifting. Those of you that are fire-based are doing even more. When you put on all your turnout gear and are lugging equipment up and down stairs, just make sure that you're on the lookout for heat-related emergencies amongst yourself and your colleagues. If you recognize signs of heat exhaustion, heat stroke especially, don't be afraid to stop, take a break, strip down a little bit, cool off, drink plenty of water, especially on those fireground situations when you need to establish a rehab sector to provide some of that cool off and rest time for your colleagues. With the closure of St. Joseph's Hospital earlier this year, all of the other East Metro hospitals have seen quite a significant spike in ER volumes. I'm sure many of you have noticed this as it relates to diversion status, as many of the inner ring hospitals have gone on divert much more frequently than maybe they have in the past. It's a real issue right now in the East Metro. We are definitely short on hospital beds, and the ERs are definitely feeling it. Fortunately, Regions ED is building out their Pod B, which as you enter through the ambulance doors will be to the left of Pod A. That is set to come online here later, either this month or next month. So you'll see some changes around Regions Hospital, hopefully for the better. Hopefully it'll make some of that patient care and transfer of care a little bit more convenient. And finally, for some good news, there are no current medication shortages that we need to address. Everything that you have in stock is currently available and being supplied by our pharmacy, so we don't have anything to report. Same with equipment. There are no major equipment changes coming up. I know several of your agencies may have transitioned to a different video laryngoscope recently, but so far all of the equipment supplies are green status, so we can continue with business as usual and no guideline changes. That's all for this month's update. Stay tuned. We'll see you next month.
Well, that's a wrap for this video. Hopefully something I said was helpful, but you never know, right? Let's go back a few months to our last video. The trivia question I presented asked how the Romans calculated the exact date of the Ides of March. Unfortunately, my list of responses got deleted during an email transition, so no one gets any fame or glory today. The answer to the question, though, is that the Ides of March traditionally fell on the first full moon of the new year. Over time, this was simplified to land on the 15th of March, as the Ides referred to the middle of each month. There were several correct responses, but sorry I can't call anyone out this time. Since this video had a segment on airway management, the trivia question for this month is this: what is the current world record for breath holding without supplemental oxygen? Submit your best guess to regionsems@healthpartners.com for a chance at a shout out in our next video. And I promise we won't lose the emails this time. As always, send any questions, comments, feedback, or ideas for future videos to us at regionsems@healthpartners.com. Thanks to Stillwater Fire for the free boat ride today, or at least I think it was free. Don't forget to check out our social media channels and subscribe to get all of our future updates, because you never know when that next video might drop. For the entire team at Regions EMS, I'm Dr. Peterson, and as always, stay cool, stay smart, stay safe, and stay professional. We'll see you next time. Hey Kevin, how do you know when a paramedic has entered the room? They'll tell you.